knowing that everything takes longer than you actually think it's going to take. So a lot of the times, and I don't know if all of you or many of you or how many of you had the project management courses, but as you know, there's always that time that you plan more in 2 weeks, give yourself that bracket that it might actually take longer. And what are your project outcomes? Okay, so this is very important for in terms of your project proposal. What are the deliverables? And what it is that you're planning to achieve. And as in other project management courses that you learn, resources, risk management, communication plans, stakeholder engagement, evaluation, and continuous improvement, which we all know that that's always happens. Okay, so as you go from those capstone projects in particular, as you go on, as you learn more, your project keeps changing, and it should be changing and continuously improving. Okay, so that's all I have. If you have any questions, please let me know. Please ask questions. So the way we are going to do it is a 7-minute presentation. I've already posted a schedule so everybody knows. I have the schedule if you want to see it or if you want me to put it in the chat. But basically, it's a 7-minute presentation that I am going to time because we have 13 presentations to go through and 3 minutes questions. So basically, there's only going to be 1 or 2 questions. And then I hope that we're going to have more time at the end where we can actually discuss it as a group a little bit more. And of course, for those of you who are here and going to the pub, we can keep the conversation going. Okay, so this is the start. Good luck, everyone. Oh, I don't know if you could.
Yeah. Can you speak up, though? Yes. You have to be really close. Okay. Yeah.
I'm going to take over screen sharing. All right. Everyone hear us all right?
People online, can you hear?
Yes.
Great. Hi everyone, my name is Sarah.
I'm Owen.
And we are the Pilot Marshall Project. We'll be doing an overview of our Capstone project, which is a case study analysis and supporting pilot project implementation. So a bit of context for our Capstone, up to 70% of patients on dialysis experience physical, emotional, and psychological symptoms which are often underreported and undermanaged. This high symptom burden can impact their quality of life, their mortality, and their transplant outcomes such as kidney transplant rejection. So at UHN, a pilot project was launched implementing an electronic patient-reported outcome measures or EPROMs toolkit for systematic symptom assessment and management. 1 month following the launch of the support dialysis pilot study, things weren't moving. Patients that were flagged as needing symptom management support were to be referred to by their clinicians.
So currently, PIs have guidance on adhering to ethical standards, ensuring rigorous research methodology, but when it comes to the current state of implementation, we're lacking. PIs implement projects often without guidance, relying on word of mouth or learning as they go. Unfortunately, as is the case with support dialysis, projects may encounter challenges independent of the health intervention's efficacy on an individual scale or despite successes in another context, in our case, cancer care. So real-world dynamics can lead to ineffective pilot project implementation. PIs need support in implementing their pilot projects within unique, complex systems environments. And that's where the Pilot Marshall Project comes in. We aim to support pilots as they take off.
So how do we do this? The Pilot Marshall Project design follows a 2-phase study approach. First of which we're understanding the context of the problem, and the second part we're acting on it. So after clarifying our human-centered problem needs care. We are using the support dialysis pilot study as a case study to identify the key barriers and facilitators PIs face in pilot project implementation. So based on this data, we will then conceptualize and develop a process model to help marshal PIs down the runway, ultimately testing and iterating this process model within the Kidney Health and Education Research Group at UHN.
So today we've achieved several milestones. Some of these will be a little bit of a repeat from our last presentation in December, but we'll quickly go over them. When it comes to capstone topic selection and problem alignment, might be a little bit of broken record for everybody here, but being open to change, don't getting attached to ideas, and as well scope. Everyone wants to like change the world, but start small and we'll work our way up from there. Talking to topic experts early on was also really important. Consulting with them is really just networking even for your pack and having people to connect to. Further learning that we also were able to take advantage of electives in relevant areas. For us, it was qualitative methods and implementation science. And in the same vein, it was also really pack networking, having professors, one of our professors actually ended up being on our pack, and also, even though we just took it this term, but he would also have been willing to.
So since the last time we met in December, in the new year, we have some additional milestones, first of which we have assembled our PAC committee. So some advice we have on that front is focus on whose expertise do you need, whether it's specific perspective, whether it's insight on methodology, whether they're an expert in their field. Ultimately, they're there to help you and advise you. So whatever gap you feel like you have, kind of keep that in mind when you're searching for potential PAC advisors. Also, we received our REB approval as of March 6, 2024. This, as I'm sure you know, or I've heard through the grapevine, it's a long and arduous process. So some advice we have on that is triple check your documentation, make sure things are as crystal clear as possible before you submit. That way you'll have less revisions to go in future iterations because you're reading the questions really well. Also, manually review your submission for REB comments. We didn't get any email notifications, so this is on you to keep charge on what you're doing. Also, make sure that the waiting time is used wisely. So what we recommend is reviewing and preparing for your next steps. So what we did was really familiarize ourselves with methodology and our study design. Anything you can do without REB, work on that. So whether it's doing some in vivo training, tutorials, getting used to the software, doing some interview prep, and kind of talking to people, getting them aware that interviews are coming as soon as you have approval, helps get the ball rolling.
So as Sarah mentioned, we were able to, once we did get REB approval, we were able to hit the ground running, and we're well over halfway done our interviews. In the context of some learnings for recruiting for these interviews, considering Circle of Care as a point of entry for recruitment, whether it's PIs, talking to other healthcare providers, if that's one avenue. Another one is, for us, we were able to talk to some research students who were familiar, who did recruitment in the dialysis center for previous projects, and they were familiar with the patients there. So they were a good point of entry for us, and it's really familiar faces is the term that we use a lot. In the context of actually conducting the interviews themselves, we were doing a lot of interviews in a dialysis unit, which is very busy. It's pretty noisy. There's lots of hustle and bustle. Even things as it goes so far as to make sure that your recording device is close enough to the person you're interviewing. Things like having backup recorders is really, really important because you don't want all this time and this good information to go to waste. Also, don't overbook yourself, making sure that you have some flexibility in terms of time after and before, people move around a little bit. We've also managed to develop an initial codebook. Familiarizing yourself with data is really important in that process. As Sarah mentioned, going through the tutorials for the software of your choice and then practice coding, which we were able to do in our qualitative methods course.
So where do we go from here? What's next? We are still completing our interviews. We still have to interview some healthcare providers, patient participants, and currently with those interviews, we'll be doing our qualitative analysis, ultimately integrating the consolidated framework for implementation science with our inductive codebook. Once we're done the qualitative qualitative analysis, we'll do some number checking, and then move forward with conceptualization and development of the preliminary process model, and then ultimately test and iterate the process model with her, hopefully in June. Thank you for listening. That's the project.
We had a request actually, my apologies, I did not mention it, I don't think you didn't mention it. We have some sensitivity to noise amongst our peers. So for today and moving forward, we'd like to just snap or wave thank you, and instead of clapping loud, just to respect others.
Perfect timing.
Questions?
I mean, for.
Yeah. That's time.
Hello, am I audible?
Yes.
Awesome. Thank you for the presentation. I did have a question on the method that was used. So we know that you did interviews, and kind of reflecting on the challenges that you faced during interviews, especially with the noisy setting and the busy setting with the patients. I kind of wondered, were there any other methods that you considered other than interviews to gather your data with the patients?
Yes, primarily, the reason we're doing interviews is because we're looking for kind of individual perspectives. So in the sense of focus groups were kind of out of it. We didn't want to do surveys because the whole point was to have these open-ended questions and feel out what worked, what didn't work for the different participant levels.
Yeah, I even expanding on why we didn't do surveys. Our toolkit itself is a type of survey.
Yes.
And one of the main pieces of feedback that some of the dialysis patients were having is difficulty completing the survey on their own. And you know, things like eyesight and you know, time, fatigue. So being able to be in person was something that made the most sense for us.
Yeah, and we had the option of doing in-person and virtual, and now we got an amendment for telephone interviews with healthcare providers. It's just that it so happens that in-person interviews was the preference for everybody who reached out to. So we got to kind of adapt to what they would like.
Awesome, that makes sense. Thank you for clarifying that.
Maybe we can.
For the mic.
Okay.
So maybe you covered it on the looking at that part. So I understand that this is meant to do a case study for this particular project and hopefully be able to scale it across other kind of projects with similar. How are you measuring the success of it after you've implemented? So how you can measure the adoption of it beyond the case study?
So
Repeat the question.
yeah. So the question is, with the process model, how are we going to measure its success and its adaptability? So that was initially part of it, but because of scale, we're not scaling it up. What it is we're developing, it will be essentially its first iteration, and then those who consented to be part of the development and feedback, we're going to create this process model. We're working with the Kidney Health and Education Research Group. They'll be the ones who are providing their feedback initially. It'll just kind of be version 1, prototype 1. Just in terms of feasibility for the timeline, I think. It'll be a completely different project if that was the full capstone.
Thank you. Carl?
Yeah, sorry. Yeah, I just would like to say that I loved your slides. I thought they were neat and organized. On one of your slides, you mentioned that we shouldn't worry about the research question. So I just wonder why you indicated that on your slide.
It was not a question, it was don't stress out the problem because it will change often. It was more close to that. So like we had our initial problem statement and that had a lot of revisions, narrow scope, and then okay, it's too specific, now spread it out a bit again, make sure it's clarified. So in the sense of don't stress about having to do this.
Yeah, don't get attached to one particular.
Right. I just wonder, in your REB submission, in your initial REB submission, so you indicated a research question, I imagine, and then did you have to change your research question along the way, and did you have to apply for amendments to REB when you had those changes, if any?
We're in a special case with our RFP is that we had an administrative review. So what was submitted was the initial UHN RFP approval for the pilot study, and we were tacked onto that RFP by being part of the evaluation process of the initial pilot. So we did not submit a brand new RFP submission, so I can't really speak too much on that. Our involvement, or what we're going to do this submission, was with all the documentation that was already approved at UHN, and then write about what is U of T's involvement, which is basically ONI schools.
Yeah, it was a program evaluation, like the feasibility of the pilot, and assessing the implementation of the pilot was part of that. So I don't think we have a specific answer to that question.
Because we don't have experience in that specific, but I'm sure other people online or here have gone through something.
Amendments are always a possibility.
Yes, that's probably the first one.
Thank you.
Okay, next group.
Is it possible to get the microphone? I think something online to
Are you testing the mic, Arnie? No, we can't really hear you. It's a bit muffled.
Yeah, it's not very clear.
No.
We'll repeat the question. Just try it in the mic and I'll repeat it.
Presenting.
We're presenting. Sorry.
That microphone was fine, the one I was using. Oh, yeah.
And let's check that out. So that one's not causing an issue. There you go.
Okay, testing. Is that better?
It's
It's a
much
bit better.
Better? No?
Yes.
Yeah, okay, perfect. Awesome. Okay, we'll get started. Hi, everyone. We are Team Protecting Our Protectors, composed of myself, Jenna, and Smega, and we're looking at investigating strategies to mitigate exposure to smoke pollution for wildland firefighters in Canada. So our project centers the lived experience of wildland firefighters, where we aim to collaboratively tackle the challenge of occupational smoke exposure without effective mitigation strategies. So a problem is that wildland firefighters face significant exposure to smoke air pollutants without mitigation measures. The need is for effective mitigation measures to reduce wildland firefighters' long-term exposure to smoke air pollutants. And that brings us to our research question of what strategies could optimize the mitigation of long-term exposure to smoke air pollutants for wildland firefighters. So in brief, the occupation of wildland firefighting is being impacted in a changing environment. So more recently, wildfires have begun earlier and lasted longer, meaning an increase in days of exposure to wildfire smoke. So this probes the question of how this exposure will impact health and well-being. So although much research is still needed, preliminary findings reveal that exposure to higher concentrations of smoke, exposure over prolonged periods without proper protection, increases the risk of harm to health. So what exactly happens physiologically when we inhale smoke? So researchers are still attempting to unravel this phenomenon and quantify the limits of exposure which would have harmful impacts. Here's what the current evidence reveals. Firefighting was recently classified as a carcinogenic occupation in 2023 by the International Agency for Research on Cancer. And there are two predominant routes of exposure: skin contact and inhalation. If we take a look at the most researched pollutants, these are the toxins and gases in the smoke in the air. We have particulate matter, which is reported to be the largest threat to wildland firefighters, impacting their lung, heart, and vascular health. Carbon monoxide interferes with the body's ability to deliver oxygen to the organs with symptoms like headaches, fatigue, and dizziness. And lastly, PHAs, which can increase risk of cardiovascular disease. So when we think about all these invisible threats that can't be seen to the naked eye, wildland firefighters are constantly exposed to these pollutants for prolonged periods of time without proper respiratory protection. We have 3 phases in our research design. Initially, we conducted a survey that was distributed across Canada to wildland firefighters, and we just aim to understand their experiences with smoke pollution and also respiratory protection. Next, our ideation session serves as a collaborative platform for wildland firefighters and subject matter experts to come together and generate ideas for smoke mitigation. And our goal here is to really foster diverse and innovative thinking, focusing on the specific needs of wildland firefighters regarding respiratory protection, and coming up with something that is ultimately comfortable, effective, but also practical in their environment. So following the session, we will work with engineers and a smaller group of wildland firefighters to translate these ideas into a prototype. So we want to make sure the intervention is sustainable. So we will also be filtering these ideas based on feasibility, viability, and desirability criteria. In terms of our progress, we are currently in our final phase of data analysis. So we completed our first round of analysis on survey data, and now we're looking forward to analyzing our ideation session data. And then from there, we'll move into our co-design phase of building a prototype. Our survey analysis reveals key insights into the experiences and health concerns of wildland firefighters. So firstly, around 60% of participants have 3 or more years of experience in fighting fires, with majority from British Columbia. We also identified key opportunities to enhance health protection for wildland firefighters. So wildland firefighters found it crucial to mitigate exposure to harmful dust, polluted air, and smoke to prevent respiratory irritation and also reduce the risk of cancer. It was also revealed that the most concerning aspects of PPE design include issues related to restricted breathing, impaired vision, and discomfort. And then lastly, we identified opportunities for an intervention to mitigate exposure during different occupational tasks. So we found that 43% of respondents see the most opportunity for an intervention during most offensive duties like direct attack, ignitions, and burnout, and then 40% in post-offensive tasks like patrolling and mop-up. So we held our ideation session this week, and we focused on mitigation strategies for respiratory smoke exposure based on these occupational tasks informed by the survey responses. So first, we focused on offensive tasks, so when they're in direct contact with a fire and exposed to lots of smoke. And then the second phase, post-offensive, when they're resting or doing tasks with less exposure to smoke. We had subject matter experts from the field of engineering, occupational health and safety, environmental, and also lived experience champions who helped gear the conversation towards ways of mitigating smoke exposure. And during the session, we generated innovative ideas, ways to improve existing ideas, and key insights and considerations moving forward into our co-design with engineers. In terms of next steps, we look forward to doing our analysis on the ideation session information, and then from there invite the engineers and wildland firefighters to see what kind of prototype that we can build that will be sustainable but also impactful, and then also simultaneously prepping for the LMP conference. Some lessons we've learned along the way: firstly, time management, especially when you're planning for a collaborative session. Allocate for more buffer time than you think you need, and be intentional with the activities that you plan to engage your participants with to make the most out of the time you have. Facilitation, also during sessions like these, it's important to have a note taker. Initially, our team wanted to facilitate and note take at the same time, but I think the best thing that we did was to get support from our peers to assist in note taking, so that allowed us to kind of focus our capacity in ensuring an engaging discussion. And then lastly, for project management, we suggest keeping track of your tasks on a tool that's accessible and easy for your team. We found something simple like Apple Shared Notes worked best for us. And yeah, that's it. Thank you. I see Derek, you have your hand up.
Okay, questions? Derek?
Hello, how's my audio?
Yeah, we can hear you.
Good? Okay. My question is, I understand you guys are making a prototype. Is there any thoughts of commercialization in the future for you guys?
I can take this question. So, as of now, we do not have any thoughts of commercialization. We're not even sure that we would be able to like generate a prototype, or it'll be just in an idea phase. So it'll be depending upon the data analysis, which we're going to do in finally from the ideation session ideas. And then we'll be moving forward with a session with the engineers to work on a prototype. So no plans of commercialization, but we plan to take this project forward for sure.
I can jump into just building on what Sumega said, agreed. And we kind of got feedback, constructive feedback that even, like Sumega said, designing something and testing it, that's another big thing that we want to reach is the testing phase to make sure that the design is safe and it does the function it's supposed to do. That's already going to take time and we might not reach that phase by the time of our capstone. But the engineers that we worked with expressed interest to potentially continue with the project and with the ideas. So hopefully they can reach the phase of commercialization and maybe we'll even still be involved in that. But for now, we kind of want to get to filtering down the ideas, figuring out what is most feasible and desirable for the prototype, and designing it and testing it will take probably the bulk of the capstone project.
Thank you.
Thank you for the question.
Hello, can you hear me? I'm not online over here.
Oh, hi.
Hello, great presentation.
Thank you.
Your project's one of the most memorable ones so far. I remember. Everyone's
That's good.
For our case study in our first year project, we're also planning on doing an ideation session, like a co-creation type session. So I just wanted to ask you, how did you structure that? And now that you've already done it, in retrospect, do you think you would have involved people who design PPE along with the firefighters to like facilitate a discussion?
Yeah, that's a good question. I think as a team, we were really intentional with the expert panel that we chose with the specific people that we wanted. We noticed that, especially when you bring in people from like occupational health and safety or like people from PPE, they usually have more of a boxed type of way of thinking, whereas the engineers and like the lived experience champions kind of had more of an open, innovative approach to the problem. So I would just be considerate of how many experts you bring in from certain fields that might not bring in that innovative approach to thinking, but it was still good to have that kind of realistic approach of like what the PPE could actually look like as well. Yeah.
Thank you so much. Looking forward to all the more projects.
Thanks, Drew. Health track. Is ready?
Hi everyone, my name is Anissa Hassan and my colleague is Fahim Mohammed Iqbal. Our project is diabetic neuropathy self-assessment using the monofilament test. Okay, so this is our team and our PAC committee members are Dr. Charles, a neurologist, Dr. Carolina, also a neurologist, and Catherine, a chiropodist. And we have our esteemed supervisors, Dr. Joseph and Editor Ferriman. Editor Malcolm. Okay, so our agenda for today is we're taking you through understanding what diabetic neuropathy is. Then we talk about our need, problem, pair, and our research question. Then we move to our journey so far, the stakeholders we've engaged, and the ecosystem map, then our proposed interventions and challenges and lessons we've learned, and our next steps. Okay, so throughout the world, it's been estimated that in every 30 seconds, one leg is amputated due to diabetes. One in every 10 adults has diabetes. And it is predicted that by 2045, 783 million people would have diabetes. And diabetes leads to diabetic neuropathy. And diabetic neuropathy also results in diabetic foot ulcers, which can cost individuals their legs. Yeah, so we'll take you through understanding what diabetic neuropathy is. So diabetic neuropathy is a complication which arises from high sugar levels that causes damages to the nerves. And we have over 28% of adults living with diabetes in the US developing diabetic neuropathy, and 50% of adults living with diabetes in Canada getting diabetic neuropathy. And it results in foot ulcers and impairs the general quality of life of these individuals. Okay, so our need is, we think there's regular remote self-assessments of diabetic neuropathy. And our problem is regular assessments of diabetic neuropathy is challenging due to the lack of access to health professionals in rural Canada. Our research question is, how can we create a remote patient-initiated home or community-based self-assessment method that can aid in the diagnosis and monitoring of diabetic neuropathy patients? So this is our journey map so far. We went through our self-assessment through exploration. Then we finally decided on coming up with a diabetic neuropathy self-assessment tool. We did a customer discovery interviews where we assessed individuals' perceptions of self-assessment tools. Then we went to do literature reviews on screening and detecting diabetic neuropathy. We then identified ideal tests for assessing self-assessment of diabetic neuropathy. We selected the monofilament test, and we proceeded to understand everything that goes with conducting a monofilament test. We assessed the pros and cons and the difficulties that may arise from using it. We created an instruction video to be able to assess how people could examine themselves using a monofilament test, and we try to assess how this may work differently in different populations. We then proceeded to form our PAC committee, and our REB submission is underway. And after that, we then proceed to testing on subjects to assess the effectiveness of the evaluation materials that we are producing. And after that, we hope after we get the feedback, we proceed to our data analysis. Yeah, so we engage in stakeholder interviews, and we've had discussions with a whole bunch of people, including patients and their caregivers. And we had two major discoveries where individuals told us that there's really a need for self-assessment tools for diabetic neuropathy. And we also realized that people wanted something that is free or at a low cost, and something that is easy to use, something that is portable, and something they could easily navigate. Yeah, so these are the findings we had from our stakeholder engagements.
Thank you, Anusatu, and hi, everyone. So we also created, along this stakeholder journey and literature review, an ecosystem map of the self-assessment tools in general. So we wanted to see which people and which stakeholders are at different stages, who are the end users, who are the expert users, who can fund, and who are the regulators. And we created the ecosystem map to better navigate a commercial viable opportunity for this kind of self-assessment tools. So how did we come up with the monofilament test? Anusatu has already explained. So the physician usually does a clinical methods and lab-based test to diagnose and to monitor diabetic neuropathy. The gold standard test is nerve conduction velocity test. but it's an expensive test and there is a lot of cost involved and it's not available everywhere. So we wanted to see which test is feasible at home or community level, easily done, less pricey and less complex, and easily to be adopted by various kinds of people. So we individually selected, we individually did some research on all of the tests, finding the pros and cons. And finally, initially we selected 2 tests. One is the Michigan Neuropathy Screening Questionnaire, which is a simple questionnaire which the patients can fill up. And the next one is the monofilament testing. So, but to narrow down our project focus and to really work on one single idea, ultimately we choose monofilament test. So what is a monofilament test? It's a quick test using a thin wire to check for loss of sensation. So it's a simple wire. It's available in Amazon and anyone can buy it, but it's not widely popular all over the globe or all over Canada. So our goal is to make it available to everyone. Then along the journey of our stakeholder engagement, we found this particular challenge on me. People lack knowledge of how to test on themselves and or on other caregivers. There is a severe lack of knowledge and lack of awareness. So there is a knowledge translation need. So this knowledge translation need, to address that, we created some instructional materials, video, text, and infographics. And our aim is to allow patients or any caregiver to follow the instruction videos and do the test themselves without direct physician supervision. So our next plan would be to recruit some volunteers of different walks of life and get their feedback via survey on the effectiveness of instruction materials on performing monofilament test. And our aim is to improve instruction material from the data gathered from the self-assessment tool trial. So how does this all work? So let's suppose Jack is a diabetic patient. He lives in a rural Ontario, northern Ontario, rural Canada. And you know that there is a lack of physicians and lack of specialist physicians, especially in Canada. And the appointments are really 2 to 6 months apart. So Jack goes to his specialist endocrinologist every 6 months. So what happens in these 6 months? Is there any way he can assess himself? Is there any way to create the red signal or the early warning system? Currently, there is less way, because Jack has 2 problems. He doesn't know that this test exists, and his practitioners are too busy to educate and to inform themselves at a wider scale. So if we can provide him with the instruction material and the know-how, so that he empowers himself to do the self-test at home at a community level, then within this 6 months, every 6 months, he can monitor himself. And if any early warning signal happens, he can directly go to the hospital or send a message or report or email to the doctor or go to the hospital. And also the Public Health Ontario and Diabetes Canada will have a great role in promoting this kind of self-assessment tools, provided it's widely available and easily accessible. So along this journey, we had a lot of things to learn, and some of the tips for everyone would be, and some of them really learning from us, is that finding a topic, narrowing it to a specific level, forming a team, and team functioning, all are very important, and there are a lot of lessons to learn. And especially the interviews and talks, initially it seemed very hard, but along the way we prepared with trial and error, and continuous effort made us well. The RABC submission is really a challenge for now, and PAC committee formation was a challenge, but we really focused on the pitch, and our supervisors really guided us along the way to get the PAC committee formed. And time management is always an issue for graduate students, and prioritizing scheduling is really important. So our next steps would be to modify the instruction material, get the RAB approval, get the 15 participants done, tests done, and analyze that data. Thank you so much, and questions we really welcome. Thank you so much.
Hi, thank you for the great presentation, Naheem and Anisatu. I was just wondering, you talked about in your proposed intervention slide that the monofilament test is not very well known. Is there a specific reason for that, or is it just lack of knowledge among people that the test is not much popular?
Thank you for the great question. I think there are two specific answers. One is the complexity of the test. So the test is a little bit complex because there are multiple steps involved, and usually this test is done by the providers, like the physicians, endocrinologists, at their clinical setting right now. So doctors do that at their clinical setting, and so our main aim is to see that whether this test can be done successfully at home or not, because people with training, we believe, can do the test at this successfully. So that's the one thing to find out. So yeah, So this is the one thing. And the other thing is that is the availability of the kit. People don't know. There's a lack of awareness. So people don't know that these kits are available everywhere. So this is awareness part as well. Thank you.
Thank you.
Your presentation was really nice. I really liked the topic. I wanted to know, you mentioned that there were 2 tests that you guys narrowed it down to, and then you chose the monofilament one. I'm not sure if I missed it, but I wanted to know what are the factors that came into play in the choice? Why did you decide to choose the monofilament one and not the other one?
Yeah. Anissa, do you want to go and then I can add?
Take that. So with the Michigan neuropathy screening questionnaire, it's something that has already been established, but we realized that it was so complicated because when you are scoring it, you may get sensations or not get sensations in your feet, and you would have to record it wrong or right. Like there were just a lot of complications with using it, and we wanted to provide something basic for individuals to just be able to use. So we decided on the monofilament. We actually spoke to a neurologist, and he told us that this will be because it's easily something someone can easily get off Amazon. And if we're able to get an instruction manual for the person could do it themselves or just give it to someone to just try it on them. So I think we factored in easy use to be able to come with this, because as compared to the 2, this was actually the most accessible and the easiest to use. Yes.
I just add to what Anissa has said. Just to add one thing is that initially we thought the combination of these 2 tests will give the most value, but then again focusing, because the Michigan neuropathy screening is only a questionnaire and people can fill it up and then have the result. But we really want to see focus. I think the focus is important here. Dealing with the 2 tests at the same time would be a little bit wider focus for us. So we just wanted to create the instruction materials and allow the patients to do the monofilament test. Yeah.
So I just want to ask and follow up, I'm getting that you had the expert opinion from the physician and then also what you guys tried it, but I mean, isn't what Joseph is always encouraging us to do is to check with the patients or the end user? So wouldn't it be more prudent to get their opinion?
Yes.
Right, exactly. We talked with almost 50+ stakeholders like physicians, patients, caregivers, and our realization is that in our project we cannot do everything at the same time. It's really important to focus only on one single aspect to just narrow down, because initially we even considered the hammer test and the other tests, different types of tests as a package. Then we asked the neurologist that what if we do some package of multiple 5-6 tests and promote it. Then he said that no, just focus only one thing and see how it goes, because there is a time limitation, and then having one variable should be better. Yeah. And you're right.
Makes sense. Thank you.
Let me also come in.
We're gonna move on. Sorry, I'm sorry. Okay. Yes, I will. So I'm gonna let Mayana have a quick comment, and then we're gonna move to the next group, because I'm hoping that at the end, and these are actually very good questions about who do you ask, what is actually required, that I hope that we have time at the end with all the groups presented, we can actually have that discussion on a little bit deeper level. Yes.
So thanks for trying to address an unmet need. I think that explanation was very useful. Just 2 quick comments. I think on your slides, they were a bit too crowded, too much text. It was hard to read a lot of the slides. So I would definitely say maybe focus on the aesthetics and the presentation of your slides next time. And just a tiny optics thing, testing with participants as opposed to testing on subjects. I think that's a very small thing, but often gets overlooked. You're not testing on somebody. They're not subjects, they're participants to your research who are contributing to the work that you're doing. So small thing, but useful to know. Thank you.
Very good comments. Thanks, Diana.
Thank you so much.
I hear.
Okay, thank you.
You guys ready?
Yes. Can you hear us online?
Yes. Do we need these two mics? Oh, this is just right here. I understand. Okay, ready? Hi, everyone. I'm Morgan, and I'm here with Carolyn and Spiksha, and together we make up Team iCare. We're going to talk to you about our capstone our capstone project today, which is all about developing a model of care for a new primary healthcare center at the Eva Rothwell Center in Hamilton's Keith neighborhood. So the Eva Rothwell Center is a pre-existing community hub within the Keith neighborhood that offers social supports and services to local residents. And the Keith neighborhood is a region in Hamilton, Ontario. The residents of Keith neighborhood are disproportionately affected by the social determinants of health. They have drastically poor health outcomes, and the neighborhood is also a healthcare desert. So for about 68,000 residents, there's only 2 primary care doctors in the area. So there's an established need to bring primary care to the area, and the role we play in this project is that there is not yet a model of care for the delivery of services through this new primary care clinic. So just to reiterate, the need that our project focuses on is the need to establish a responsive model of care for the Eva Rothwell Center primary care program that is context appropriate. And we're going to do this by conducting semi-structured interviews with 2 different cohorts of participants. The first participants are residents of the Keith neighborhood that don't currently have a family doctor, as they will be prioritized when this clinic opens in the coming months. And the second cohort are healthcare and social service workers that work within the Keith neighborhood. And we're going to use the qualitative and quantitative data from those semi-structured interviews to inform a model of care that we're going to pass over to the Hamilton Family Health team who will be operating this clinic.
Okay, now I'll talk about the progress this far. Last summer, we started with project planning. So we formed our team, we completed our project proposal, and along the way, we developed relationships with key stakeholders, and we really refined what our scope was, and talking to different people, doing a lot of literature reviews on key topics. For example, like relevant to us was like social medicine and like what a model of care is, and really refining what our methodology was. We also formed our PAC committee along the way. Once we had all of this in set, we applied for REB, we got accepted, and we started with our recruitment of our first cohort, which is our community member cohort. So we completed our recruitment poster. We went to the Eva Rothwell Center and nearby community hubs for in-person recruitment. This is still going on, but simultaneously, we also started our interview preparation. This included doing our completing our REDCap data management tool, really refining our interview guides from mock interviews that we did with our family, our friends, even classmates, and then scheduling those interviews. And we have our first interview tomorrow. And we also, Carolyn participated in the 3-minute thesis, and she ended up going to the final. So another round of applause for her. And we went to Vegas last week for the Translational Science Conference, and we did our presentation. So many applauses. Okay, next steps. Our next steps would be to finish our community member interviews, as well move on to our service provider interviews and recruitment. Once we have all of these data collected, analyzing them through NVivo, and then essentially, like Morgan said, have a list of priorities that we give to the Hamilton Family Health team to integrate as to what services and how those services should be offered in this new clinic. We also have applied to the LMP conference, the medicine showcase, and also Hamilton Health Sciences conference that we are waiting to hear back on.
And next, we're going to talk about some of our lessons learned in our project so far. And actually, a lot of these were already reiterated in other groups, including what Edita said at the beginning. But just starting off for a group formation. Oh, thanks. Wait, let me see. Is this better? Better, okay. We wanted to start off just talking about how we formed our capstone group, because I know a lot of the first years are probably in that stage right now. Oh, thank you, thank you. So we wanted to say that for us, it really worked for us to form our group based on our dynamic between the three of us and not necessarily one common topic that brought us together. We also found a lot of success in partnering with an organization or a project that was already existing and kind of adding value through a translational lens and marketing ourselves as something that could help further the reach of that project. And we found it really helpful as a group of students to join into something that was already existing. So just an encouragement that you don't necessarily need to start from scratch. It can be helpful to add yourself onto something existing. Not to underestimate the importance of organization. So finding something that works for you in terms of organizing your files and documents. So for us, it was creating a SharePoint, like a shared document folder. Next, finding ways to be efficient early on. So for us, that was creating templates for things like rapid updates and meeting minutes or agendas to really make sure that you're not wasting your time doing the same thing over and over again. Then again, we heard it before, keep your scope small. The project gets wide no matter where you start. So if you can start with something really specific and really be able to articulate what that is to people that you do, it really helps. And next, again, was said before, we're still learning this. I think it's something that we talk about all the time is that things take so much longer than expected. And I think we heard that a lot in the context of an REB application, but even just the normal steps to the project. So we found when it came to communicating to our stakeholders how long things are going to take, we're kind of trying to say, we're trying to give them a timeline that's 2 times as longer as we think intuitively it will take. And that honestly has been better for us and more aligned, more realistic. Kind of on the note of timing, expecting that the momentum of the project will change as the year goes on, especially at just times where you have less energy, like the end of semester, after Christmas, and just to pace yourself for that. And it's okay if that happens. Next, start looking for knowledge dissemination opportunities early. Apply to go to conferences or things like that. Even if you feel like you don't have results, it's fun and it helps build up your project and your network. And then kind of ironic because we're giving advice right now, but honestly, like everyone has advice for you and it can be overwhelming. So take everything that people are saying, including what I'm saying with a grain of salt. And yeah, just trust your own intuition when it comes to your project and reach out to upper years if you have specific questions. And lastly, on a light note, we wanted to say, invest time in strengthening your team dynamics. We have a lot of fun together. Have check-ins, provide feedback, celebrate your accomplishments. And this is our last slide that Civixa prepared, which includes some photos from our project. Yeah, some of these are from Vegas and other recruitment activities, but thanks for listening and we welcome any questions. Keep this slide up. Take it.
I just want to congratulate you. I really like this project and this team. You just seem like a very fun team, something that I would want to be part of. Question that I have is, I really like the advice that you gave that maybe partner with a project that already exists. And we were just talking about this like in our first year class. How do we like market ourselves as TRP students? Like, do you have any advice of how do you find that a project that already exists and then we can work on that? Like, how did you find about this clinic needs help?
Yeah, that's a great question.
Yeah, that is a great question, and feel free to jump in, team. We get that question a lot because, anyway, the answer is Carolyn leveraged her personal network. And we kind of just like, when we were at the process of trying to identify or find a project, we just kind of unapologetically talked about it all the time with everyone. And then eventually someone was like, great, I have an opportunity that would be perfect for you. And so it wasn't, I don't even think we did that consciously. We were just kind of all stressed about finding a project. And so people would be like, hey, how are you? And we'd be like, stressed. Do you have any opportunities I can take advantage of? And Yeah, I lost my train of thought. Feel free to elaborate.
I think that's really well said, Morgan. I think just keep at it, put the ideas out there, and don't discount anyone. Like talk to anyone, even if you think they can't help you or aren't relevant. Just put it out there, and something will come to be. And don't wait for something like a project that feels a little bit exciting or feels like it's pulling you. Don't commit to something early just because you're stressed to find an idea.
Passionate about the project.
Okay, great presentation and like way to be clued into like one of the greatest needs in Ontario healthcare right now, which is primary care. It's totally cataclysmic situation we find ourselves in when it comes to primary care. I have two questions, either answer both. Can you elaborate a little bit more on your definition of what is considered context appropriate modeling? And what are the criteria that you have to find to ensure that this model actually is, in your words, context appropriate? And then the second question is, how is your proposed model of care different to the current model of care that they have at the care center? A little bit of background on how they're currently operating. Nice. Thanks.
Okay, I can start with the current model of care is just a physician, a psychiatrist, an NP possibly, and I think that's about it, maybe a nutritionist or a dietitian. So we're specifically looking at like what are those extra services that this population needs, which is where the context appropriate piece comes in. So it's not that there is like a general idea of what care should be given, but specific to the Keith neighborhood, it's a high immigration population, low income, precariously housed individuals. So there's a lot of extra factors that are probably not being taken into consideration with the current model of care. So we're trying to kind of understand what are those additional services or how can we help you navigate those additional services if they're not offered in the clinic, like what social services do you need? So that's where we come in. I hope that helps.
I can add something.
That's great, thanks. Do you have any sort of post-implementation criteria or measurements, outcome measurements that you've determined in order to measure the success of context appropriate implementation?
Yeah, so all great questions. Something else I just wanted to add, and then I'll get to your other question, is that we are kind of looking at this as a case study for like an example that other people could use to guide future interventions in different contexts. So, and for them, it would be an emphasis on the process that we use to develop the model of care, not the outcome of the model of care. So other things that we want to include in our data collection are what hours of operation do you want to see for the clinic? Do you want it open one day of the weekend, right? Because like, you know, if everyone in the area happens to work 9 to 5s and we staff the clinic with a doctor that works 9 to 5, that's not really helping people as much as it could be. So we're looking at those other features of the clinic to make it tailored to the needs of the specific community. With the hopes that, you know, if someone were to look at this process and try to apply it in a different circumstance, they can say, okay, you know, these researchers, when they had interviews, whatever, they gathered data through this method, and we can do the same thing. But the end product would look different for them. And then super quickly, we are also mindful of an evaluation plan. That's kind of on the back burner for us right now because we're just trying to get into like the actual heart of the data. But part of our deliverable, if everything goes as planned, we'll have some sort of evaluation piece about how, because you know we're not going to be on this project forever and ever, and that's kind of also what we meant by the word responsive. We recognize that the community will change with time, and we want to propose a method for the people who remain engaged in this project through into the future. How can they check in with the community and say, is this working? What do you need to improve? What can we change, etc. So that will be part of our final deliverable.
Thanks, Jamie.
Thank you. Okay, we're gonna move on. And I'm sorry this is a little rushed, but we do have a lot of presentations. I would like this to be one question.
okay?
Yeah.
Yes, beautiful.
Wait, they said no.
I say yeah.
Hello. Is it working? I'm sharing screen. Is this better? Hello, can you hear? Online here.
Can someone online say something?
Or just put it in the chat. Yeah, can you hear us or can you not?
Yes, we can hear.
Yes, they say yes. Okay. When was the last time someone asked you how you were and you responded with, I'm not okay, or I need help? Both phrases are simple to say, only 3 words in plain English, but the process of being vulnerable, acknowledging something's wrong and admitting that you need support to get through it, can be a daunting task for anyone. Now, consider that you have difficulties communicating or interacting with others socially. It's not just about admitting that something's wrong now, but knowing what to say, how to say it, and what to ask for. Now, even if you know those things, imagine that the people that you're approaching for help have misconceptions or prejudice against you that makes them assume what your needs are or think that they know better than you. The task of asking for help just became 10 times harder. This is the reality for many autistic adults living in Canada. Autism is a neurodevelopmental condition in which 1 in 66 Canadians have an official diagnosis. It's characterized by difficulties communicating and interacting socially, as well as repetitive behaviors and routines. Autistic adults in Canada are disproportionately affected by mental health challenges, including higher incidences of depression, anxiety, and suicide. While 33% of the general Canadian population has 1 or more mental health conditions, this number is more than double when it comes to the autistic community. Despite an increased need for professional mental health support, autistic adults report difficulties expressing their mental health needs to healthcare providers, whether that's family physicians or counselors or social workers or psychologists. Introducing the MEND Initiative, Meaningfully Empowering the Neurodiverse. My name is Avitha, and these are my group mates Elena, John, and Katie, and we're on a mission to address this gap. By using a participatory design approach, we hope to co-design an intervention directly with autistic adults to help empower them to communicate their mental health needs to their chosen healthcare providers. So our research question is, how might we develop an intervention that helps empower autistic adults in the GTA to express their mental health needs to their chosen healthcare providers? So you can see how we're doing that. So empowerment in this context goes with 3 different concepts. We're looking at self-agency, self-confidence, and advocacy to help individuals exercise control of their mental health. So our objectives are to improve autistic adults' self-awareness of their mental health needs, their self-reported confidence in expressing their mental health needs to healthcare providers, and their self-reported control over improving quality of life and overall wellness. So our study, which is based in the Toronto Translational Framework, has 2 phases. In our first phase, we are doing co-design sessions with an autistic advisory committee comprised of 3 to 5 autistic adults, as well as creating our prototype. And then in phase 2, we're going to be testing this prototype with 2 different focus groups comprised of 3 to 5 different autistic adults from our autistic advisory committee. So our progress to date right now, so once we became a team in the summer, starting in mid-July of 2023, we started our needs analysis, so identifying and verifying the need. And then once we completed this, we were able to develop our research question, which we proposed to
you guys. And then once all of that was solidified, we began preparing for our R&D application and searching for our project advisory committee members, which is comprised of experts from CAMH, Review, and McMaster University Autism Research Team. And so while we were waiting for R&D approval, we compiled a list of potential recruitment channels. And so once we got that approval in like early February, I would say late January, we started the actual recruitment for our autistic advisory committee, which we've completed. And then we're also still recruiting for our focus group participants. And so where we are right now, from mid-March to late April, we have been conducting our participatory design sessions with our committee, of which we've done 2 already, and we have 1 more to go, which is really exciting. And then we're also conducting our theoretical mathematical data analysis concurrently with the sessions. And so as for our next steps, so our last session in our autistic advisory committee is to ideate a prototype which we will have iterated upon, and then we'll evaluate that prototype based on the measures that Katie explained through our 2 focus groups. And then once we do that, we'll start finishing our final report for our defense. And so in between our really important capstone work, we've also hung out many times because our personal relationship is really valuable in addition to our professional activities. And then as well as attending conferences whenever we can. So we've done one in-person one, which John went to, as well as the online Health and Wellbeing Developmental Disabilities Conference that was held virtually.
Beautiful, beautiful. Now I have some friendly advice for the first years. Okay. So I really recommend you to start in summer, especially get that problem need analysis like finalized or like at the last iterative version of it, and to make sure to validate your need during the summertime. Take 2 weeks off, but not more than that. Trust me, it's gonna really help. And for that, you also need to establish your pack early because just listening around, some pack members really want to be involved with the R&D process. Like when you get R&D, get the LLM accepted, they might say, we don't like this. I need to change it like from the beginning. So like pick your pack, think about it, and get it finalized as early as you can. And also, yeah, important already, many of my cohort mates already said it, but have a detail, put everything that you want in it, like from email scripts, how you want to talk with them in person, online, Zoom, over the phone, put as much detail as you can. And start to have a draft for yourself and then just put info in it. And for the electives, try to choose something that is like beneficial for you have 2 choices, 2 electives, right? So choose at least one of them that is beneficial for your capstone, whether it can be a component of the capstone or like the whole of it, and also some qualitative courses not actually helping it. I know we had them in this class, but some additional help always helps. And also have fun, I know, because you're going to work together for a good while. So it's important to know not on work level, but on personal level as well. So something we do, even if we can't meet always in person, during our weekly meetings, we have like 10 minutes of just talking about ourselves and then 10 minutes reflection at the end of the meeting. So if there's anything you want to get off our chest, we can. And just a quick note, one of our pack members actually told us this conference is free, it's online, it's on April 23rd, it's about mental health as well and addiction, and maybe on the device improvement and quality equation. With that, thank you. Questions?
Let's go back to the slides.
I was wrong. And remember, you can always put any questions in the chat as well. Yes.
Hello. Hi. That was a really great presentation. Thank you so much. I think it's like 2 questions in one. So I was kind of wondering, like, how do you like manage like the degree of autism in terms of like the group that you're trying to help? Because there can be like, I mean, they have different experiences, different symptoms, as well as like non-verbal autistic adults. So how do you tend to create a communication platform that will allow them to express themselves as authentically as possible to their chosen healthcare providers?
So for the first part, we had to be pretty specific about who we are going to allow into the study because it's a spectrum, there's a lot of different experiences, and it would be really hard to get answers from someone who I think our picture is able to communicate in English and they could bring a support person, but hopefully they're going to be able to communicate with us through a device or words. And they have to be able to do informed and consistent consent throughout the whole thing by themselves, so they know what's going on. We also had other criteria, like they need to be in the GTA. We had interest elsewhere, but we had to narrow it down to the GTA for our timeline, as well as 18 plus. And we tried to get a range of ages. We're not just working with the students in university population, if that answers that.
I'll add one more thing, just because I think it's really important to note that, for those autistic adults, especially who can't maybe communicate the way that non-autistic people can, it was difficult because we didn't want to exclude them because they were often already excluded from not just like general research, but autism research itself. And so the criteria that we had in place allowed for those individuals to participate as well. Yes. You have like your second part, or
Oh yeah, also those were, yeah.
okay, beautiful. Leslie?
I have a question about chosen healthcare provider. Were you looking at that from like, this is the scope of healthcare provider types we needed to address because these are the categories they asked for? Or are you be empowered to select the individual person in their care process?
It's kind of the second one. So we're using the definition of healthcare provider provided by the Canada Health Act. So it's quite general, and it's anyone who's able to provide health services. But we really wanted to empower them to basically be able to communicate to anyone that they wanted to, which is why the onus falls on them as to who they want to communicate with. I think that answers the question, yeah.
Okay, thank you. We're gonna move on. Med market.
That's how you always put me after such great groups. Okay. How's my screen? You see it? Yes, no, maybe?
Yes.
Yes? Okay,
Yes,
great.
yes.
Okay. Good afternoon, everyone. I'll be presenting on behalf of myself and Zoya. We are the Med Market Mavericks, and today I wanted to take a step back, show you our project, what we've done so far, and where we're going. So introducing our team, we have myself, Zoya, Joseph, Edita, and our PAC members who provide expertise in procurement, startup commercialization, and research methodology. We have Julie Smith from UHN, Marissa Bird from U of T and Trillium Health, and Bibiswan from Obio. So let's think about how a startup would sell a health technology within Canada. In an ideal world, the startup can sell their health technology to the healthcare organization, and the patient can benefit from said technology. However, in Canada, startups face challenges when attempting healthcare procurement. These challenges, such as hospital risk aversion or lack of understanding of procurement, results in startup solutions rarely being adopted. Startup companies producing these health technologies have limited growth in Canada due to limited adoption by Canadian hospitals and other healthcare organizations. This results in the migration towards more welcoming economies, resulting in a net loss of talent, IP, cost saving, and patient benefit for Canada and Canadians. On a local level, little procurement of innovative startup solutions means that the Canadian patients are not able to benefit from the tech that they fund and support to develop through taxpayer money. Thus, we uncovered an ongoing problem. Canadian patients do not have timely and equitable access to novel Ontario-based innovations. From our problem, we determined that the need is for Canadian patients to have timely and equitable access to novel Ontario-based innovations. Why is this important? Touching more on the local impact for hospitals, having new innovative solutions for complex problems can relieve some of the stresses on our healthcare system. For the startup, they'll be able to become a business and sell their products to the hospital and develop the local economy. For the patient, they'll be able to be treated with solutions that have been proven to be better than the current standard of care. From our needs statement, we came up with the research question of how can we promote procurement of startup solutions in Ontario healthcare organizations? So how are we going to go about doing this? To answer our research question, we employed a generative co-design framework for healthcare innovation, which was developed by one of our PAC members that uncovers stakeholder latent needs and challenges. This framework has 3 stages of pre-design, co-design, and post-design. In pre-design, Zoe and I conducted over 20 informational interviews with startup executives, healthcare organization leaders, and procurement specialists. For the co-design, we will invite our participants to form groups based on similar experiences. These groups will develop personas of a typical end user and engage in building a scenario in which their problems and challenges are met. These persona scenarios will be shared with the overall group, and facilitators will lead discussions about how to go about addressing these challenges with startup procurement. Through this co-design study, we believe that we can obtain design requirements that is reflective of diverse stakeholder needs, particularly because stakeholders will have the opportunity to challenge and discuss different perspectives, build upon their ideas, and get contextualized actionable items. And finally, during post-design, we will conduct a qualitative data analysis and elucidate the final design requirements. So how did we get here? In the summer of 2023, last year, we started our Capstone journey. Zoe and I had broad interests in procurement, innovation, and healthcare startups. During this time, we were interviewing and talking to a bunch of people who could help us get towards a project. We had initially talked about procurement and pivoted away, but once we talked to more startups, we realized that this was a major challenge. We booked a meeting with Bibiswan from Obio, and suddenly we were able to gain traction. Since that meeting, we ramped up our networking and developed our project. And since starting it, we've clocked in at about 4 conferences and events, over 20 stakeholder interviews, and about 3 pivots. We recently got our REB approved last week with no edits, and we will be beginning recruitment. Some key learnings, not to be repetitive, but project and time management is important. Like yourselves, we're busy people. And with other commitments and pursuits, being able to map out estimated timelines and understand the possibility of changing dynamics of the external environment and prioritizing internal things is key to success. 2, shifting mindsets and expectations. I would say this is 2-headed. When we're exploring a problem, it's easy to get lost in the nuances of the problem, and you tend to explore rabbit holes, especially if your problem space has very intimately involved stakeholders and multiple of them. So don't get too lost and focus on the problem itself. The second head, I would say, is to manage your expectations. You have limited time, and if you're thinking about introducing partners, you now have an external group to manage as well. Having the foresight to understand what an external partner means for your project and managing their influence on it is also important. Finally, clear communication. Being able to clearly communicate both internally and externally the expectations of your capacity on a individual or group level is key to build trust and maintain relationships, and I think will be important both in your capstones and on your future careers. So next steps. We're gonna redefine our persona and facilitator guide, begin recruitment, and develop a game plan for the actual study. And that's it. Thanks for listening. Yeah, welcoming any questions.
Okay, so in this case, what we're gonna do is we're gonna have a 10-minute break. So it's 5:31, 5:41, everybody's back. Danny, here? Danny? Mindset, are you guys ready? Can you go? Oh, yeah. Okay,
Yeah, we're ready.
okay. You ready to present? Danny?
Yeah, Rita, just give me 1 second to pull it up here.
Oh. Okay, so it's gonna be mindsets, and then you're gonna go after them, okay?
Okay, I'm ready.
Oh, you are ready? Okay, so is that okay, Matt?
Yeah, no, go ahead, Danny.
Okay.
Then. He just needs to talk. And then it will switch. So that's face.
Give me a second, please.
But we saw your screen just a second ago.
Matt, can you go first, please?
Yeah, no problem.
Thank you.
Okay, hi everybody. I'm going to be presenting with Brianna and Izar today about the MindSense project, enhancing youth engagement and counseling through measurement-based care. So really excited to chat with you about this. We're going to start with a quick little video that some of you have already seen, but it's just a really quick and easy snapshot of our project.
This is Marion. She's 17, on the soccer team and yearbook committee, and is trying to keep her marks up for university. Marion's also been seeing a mental health counselor for the last couple months. She thinks it's been helping, but it's kind of hard to tell. Her counselor always asks her to fill out these questionnaires. They don't take too long. They're usually just a few questions about how her mental health has been over the last few weeks. He says these are part of something called measurement-based care, which involves using measurement tools like questionnaires to guide treatment decisions. That sounds pretty cool to Marion. It makes sense that measuring her mental health over time allows her counselor to track how she's doing and tailor her treatment accordingly. But the process isn't exactly engaging. She fills out these questionnaires, hands them to her counselor, and that's about it. She wonders how much more interesting her sessions would be if she was more involved in the measurement. She could get answers to her questions like, what's being measured in the first place? What does it mean? How does it affect her daily life? That would make Marion feel so much more involved in her mental health care. Searching for a more active role, Marion turns to the MindSense team. MindSense is a student-led project that is on a mission to develop a tool to help youth feel more involved in their measurement-based care. The goal is that this will make youth feel more engaged in treatment and more empowered to make decisions about their mental health. This tool will be co-designed with youth who have lived experience of accessing mental health care, just like Marion. Tools made by youth for youth have a better chance of being used because they can address barriers that actually matter to young people. Then when the tool is developed, we'll measure if it actually works. Does it make youth feel more involved in their measurement-based care? Do youth feel more engaged in treatment? This will be measured with a survey and focus groups with youth aged 14 to 25 across Ontario. Engaging youth this way can lead to better health outcomes, increased buy-in and sustainability of measurement-based care, enhanced relevance, and most importantly, addresses the ethical need to involve youth in the decisions that affect them. Marion can't wait to work with the MindSense team to build this tool and improve the way youth are involved in mental health care journeys.
Okay, so just a quick background on some terms you heard there. Measurement-based care, that's what refers to the routine use of validated measures like surveys and questionnaires to inform and tailor the treatment that you're receiving. And then shared decision-making is a process that measurement-based care is trying to achieve. So it's this idea that when you go into treatment, maybe you're a young person who's seeking out counseling, you're actually having a seat at the table to make decisions about your health. So it's this collaboration with your care provider. And so YHU, Youth Wellness Hubs Ontario, is a one-stop shop in Ontario that's providing integrated services to youth across the province. So this includes social services and clinical services. And measurement-based care is a really big part of what they're doing with their counseling. Although they're having a bit of a challenge with the uptake of measurement-based care. Basically, it's not being done as routinely as they would like, both from the youth end and from the counselor end. And the problem is that youth have never actually been involved in the process of how to make measurement-based care more engaging.
Thank you, Matt. I'll take over. So here we are. Here's our team. Next slide, please. I will quickly introduce the powerhouse team driving our projects forward. On the left-hand side, we have our TRP advisors, Joseph and Edita, and in the middle, we have our distinguished PAC committee, which comprises the expertise of Darren, Mahalia, and Catherine, all who bring wealth of knowledge and experience to the project. And on the right, we have our collaborators who are Deb and Joe from Youth Wellness Hubs Ontario, also known as YHU. Next slide. So the problem need statement we identified is that youth currently feel disengaged with integrated counseling services. And in order to combat this, there's a need for increased shared decision-making to create space for youth to have an active role in shaping their treatment through measurement-based care. Next slide, please. Therefore, we are asking the research question, how can the implementation of a youth-friendly knowledge product enhance treatment engagement and increase uptake of measurement-based care at YHU?
So our project consists of 5 crucial checkpoints, the recruitment of youth advisors, and then the co-design of a tool prototype with these youth advisors. Then we would refine the prototype based on youth advisor feedback and create evaluation tools with them as well. And then we would go on to actually evaluate the prototype with YHU service users that receive counseling. And then lastly, analyze that data collection and evaluation and implement it into our final tool to be implemented at YHU. So currently our team is sitting at the refining stage of our product number 3. So up until now, our team has partnered with Youth Wellness Hubs Ontario. We've formed our PAC committee and held 3 meetings. We've approved our quality improvement project through CAMH. We've disseminated our project video that you just watched via outlets at YHU and CAMH. We've also presented our project at the Frame Learning Institute conference. We've conducted youth advisor outreach, and we've established our youth advisor committee with 7 members. We've also developed our project handbook for these youth advisors and conducted our first 3 co-design workshops with them as well. So here's just a glimpse at what we've covered in our youth advisor workshop so far. In our first meeting, we onboarded our youth advisors and collaboratively established team norms. However, the session was used mainly to ideate for our tool that we set to create. The second meeting, we narrowed down the concept of our design into 3 options, and our advisors concluded that we create a measurement-based care youth toolkit with elements of gamification that would meaningfully engage them and other young people in measurement-based care at YHU. And from there, we refined this proof of concept by receiving feedback from our advisors, and we're currently working on the final version of our tool prototype to be evaluated. So once our tool prototype is complete, we will then evaluate it based on usability, understandability, and measurement-based care engagement enhancement. From there, we will refine our tool further based on the data collection and analysis from the evaluation phase. And lastly, we will implement our tool within the Youth Wellness Hubs Ontario networks across Ontario. So some notable takeaways from our project so far
are just trusting the process. Not to repeat a lot of what other teams have said, but navigating a problem space takes time. So you have to be open for change to happen along the way. And a good thing to do whilst all this change is happening is to document everything, write everything down, and make sure you know where it is, because sometimes it's hard to kind of collect your thoughts after the fact if you don't write things down. So just make sure that you're keeping good documentation of everything. Our team uses Notion, and we find it to be a really great tool. And also ask your community. Don't assume. You can always ask for help, and remember that they're the experts in their own experience. Something that we've taken really seriously throughout our process. So thank you for listening, and we're open to answering any questions.
Questions? Elio?
I think Jenna can go first.
Thank you. Awesome job. Always love to see you guys' progress. A question, since this relates to our team's phase at the moment, how did you narrow down your ideas post-ideation session? Do you have any tips for doing that?
I can start us off, and then Isaiah and Brianna, please jump in. Yeah, that's something we had a hard time with. I think for our first session, what we did was we started broad and we kept it very open. You know, here's the problem. What do you want to see, right? What would address this problem? And we did that whole come up with only bad ideas and then we tried to make it as fun and interesting as we could. And then for the second session, what we did was we kind of distilled a list of ideas that we thought were feasible. So we proposed them like a survey and a toolkit for youth, and then a toolkit for counselors, and then a couple other options. And then we just basically discussed the pros and cons of each of those options and asked them, what do you think works? Other things are on the table here, but here's what we're thinking. And it kind of sorts itself out. Like for us, they were all like, yeah, we really like that youth toolkit. Let's do that. And then we just talked about that for the rest of the meeting.
Yeah, I would say, just to add to that point, nothing that we present to them, we always say is not set in stone. So when we did have the ideation session, we did like the reactions, you know, you can put like stickers and stuff on Miro. So we did use reactions to like gain insight on what was good or what we wanted to focus on or what they wanted to focus on. But then going back to giving them options, we also opened the floor to other options that we didn't even think of. So just keeping things very open and always going back, closing that feedback loop to your advisors.
Okay, Elio, did you have a question or you?
Yes, I have a question for them. So I want to know, I'd like to know how you're going to validate this tool. I didn't understand well. Like you're going to apply to the youth patients, to the youth students at UFT, and also have you ever tried to play around those mental health toolkits that the UFT offers on their mental health student website? And how could that fit into your project as well?
Yeah, so I can also jump in there. Good question, Elio. So it wouldn't be totally relevant to the U of T student body or their resources, because I think it's kind of looking at a different population. And so we're not trying to target student well-being or address issues related. Wow, I'm just seeing how big my face is on the class screen. But yeah, so the U of T resources are not actually going to be about measurement-based care within the context of counseling services. So our population is actually going to be WIHU counseling service users throughout Ontario. And then how we're going to evaluate it is through a survey of about 50 youth over the course of May, and then recruiting some of those youth to do a focus group to give a little more feedback about their experiences with it, what they like, what they don't like, and then refining the tool from there.
Thank you. So I apologize that we're gonna kind of try to keep it to 2 questions, hopefully, unless the answer is really long. Just because we have Okay, so Danny, or do you want to go or? Not be still.
Yes, let me try to share my screen. Sorry, can you see my screen?
Yes.
Okay, work.
Can you see my screen now?
Yes. You see your notes, but that's okay. Just click on those three dots there and you can take it off the presenter view. Under the big picture, if you click on the three dots, you can take it off the presenter view. But don't stop sharing, just do it from there.
I don't stop sharing, just
You can't present it as a presenter. Okay, there you go. Okay.
can you see my screen now?
Yes. Yes.
Okay, thank you. Hello everyone. I'd like to present my capstone project called Endocrine Health, the science of endocrinology for healthcare professionals. Let's imagine this scenario. You are a middle-aged person diagnosed with arthritis rheumatoid and suffering chronic pain associated to this immunological disease. Currently using many medications, but nothing improves your pain. Finally, you find anecdotal reports in social media about cannabis as a pain relief option. But when you consult your doctor about cannabis-based medicines products, no, you don't get any advice or guidance. So now what? For thousands of years, various cultures have employed cannabis as a therapeutic agent for diverse ailments, supported by numerous historical accounts of its efficacy. However, due to the prohibition movement surrounding psychoactive substances during the 20th century, their therapeutic use and scientific exploration were abandoned for a time. Sociocultural factors have reopened the discussion regarding cannabis and cannabis-based medicinal products. Consequently, this has led to modified regulatory and legal frameworks in many jurisdictions globally. More recently, patients groups ranging from HIV and cancer patients to mother of children with rare epilepsy syndromes have become active participants in these discussions, seeking advice from healthcare professionals regarding the use of cannabis for therapeutical purposes. In Canada, the regulatory framework for medical cannabis has undergone small modifications over the past 2 decades, despite the fact that the usual rigor or the scientific evidence required for the approval of drug intent for human use has not been met. The hype, the criminalization and regulation of cannabis-based medicinal products, despite a lack of scientific evidence, have created a situation where patients use it without healthcare providers' guidance, leading to unknown the risk of adult use of cannabis. Adding to the regulatory confusion, the absence of clinical guidelines and patient expectations, the lack of health professionals training in cannabis-related issues, and the endocannabinoid system might present a potential risk for public health. So here we are. The problem is that cannabis in Canada has been at the forefront of using cannabinoids for medicinal purposes. However, medical students and trainee doctors in Canada are not being educated about endocrinology. Due to this lack of research in this area, the absence of formal medical education and training programs focus on the endocannabinoid system rather than medical cannabis. Therefore, patients have reported feeling lost and unsupported when seeking guidance from healthcare professionals. So the goal of this study aims to test to establish endocrinology curriculum as one of potential innovation pathways to augment current training practices. So the research question is, can education on endocannabinoid system improve knowledge, clinical practices, and ultimately the patient experience? So endocrinology is a novel scientific field dedicated to the study of components of the endocannabinoid system, such as ligand receptors and enzymes present in vertebrates, and their impact on health and well-being. To achieve these outcomes, this study will be divided into phases. The current study purpose use a mixed method approach, integrating quantitative and qualitative data to understand the research problem comprehensively. So the first objective of this study is to collect initial information on the knowledge gaps of medical students and healthcare professionals regarding the endocannabinoid system. This will be done through a cross-sectional study survey. And the second objective will involve the use of qualitative methods such as interventional-based component to develop educational tool by workshop on endocrinology and test it. By comparing between medical students and physicians in training, pre-intervention versus post-intervention, and it leads to analyze the intervention impact and make informed decisions based on the results. So here I am, and the next steps are learn about implementation, evaluation of educational tools for healthcare providers and continue medical education. Complete a partnership with Toronto Cannabis and Cannabinoid Research Consortium. The last week, I received an approval for poster presentation for the 4th annual TC3 Research and Innovation Symposium happening on May, at the end of on May, and meeting project advisor committee members and supervisor, hopefully the next week, submit the REB application, and develop and adapt standard cannabis knowledge surveys for healthcare practitioners in specific settings. So thank you and welcome for any question.
Thank you. Question?
I have a question to Danny. So, Danny, nice presentation. So, at what level of the medicine curriculum are you aiming to input this kind of optimization of knowledge, like med school, residence, any specific specialty, postgraduate? What just what level are you aiming to?
The first aim of this study is to test in the Temerty Faculty of Medicine. It involves med students, physician in training, and other healthcare professionals related with pain management, for example. So that's the target population.
Yeah. Okay. Thank you.
You're welcome.
Okay, thank you, Danny. Next. I think it's Anastasia, Elio. Shalini, you guys ready? Right.
Okay, I'm just trying to raise my hand here so everybody can see me, but anyways, okay. So can I start? Yes, right. So our group is composed by Shalini and I. Our Capstone project is about a study on the effectiveness of AI-powered chatbots in enhancing patient education and satisfaction in obstetric anesthesia care. We'll go over this following agenda today, and I'm going to start with the background information for you guys. I'm very happy to present this project to you. So obstetric anesthesia refers to peripartum anesthetic and analgesic activities performed during labor and vaginal delivery, cesarean delivery, removal of retained placenta, and postpartum tubal ligation. On top of this, anesthesiologists also provide a pre-anesthesia consultation at a pre-anesthesia clinic, which offers physical assessment, evaluation, and education to patients scheduled for surgery. According to Canadian Institute for Health Information, Canada witnessed over 340,000 obstetric procedures, with Ontario contributing to with 132,000 of those. At the Ottawa Hospital, the obstetric units at the civic and general campuses cater to about 7,000 births yearly, serving as a primary referral base for tertiary obstetric care in Eastern Ontario. At the TOH, about 70% of pregnant women will have an epidural when laboring, while only about 5% of women deliver their babies without any medication of some sort. To illustrate, analyzing just the civic campus, there are around 300 births monthly, composed by elective C-sections, urgent C-sections, and labor epidurals. Hence, the high volume of cases at TOH, including both normal and high-risk pregnancies, demands a robust system for pre-anesthesia consultations. Let's shift gears to the problem identification now. I've been immersed in the anesthesia environment for 12 years, and in my clinical experience, I have observed that patients often repeat the same questions during consultations, which may not necessarily require input from an anesthesiologist. This repetition consumes valuable time, limiting availability on critical aspects of anesthesia for scheduled surgery patients. A notable observation from the experience shared by TOH anesthesiologists and nurses involve extensive patient education and addressing various concerns, which often stem from previous experiences or a lack of comprehensive information. Pre-anesthesia consultations effectively enhance patient satisfaction, preparedness, and reduce anxiety associated with anesthesia. But sometimes patients need time to digest this amount of information given, consequently suggesting that pre-anesthetic consultations may not be the optimal time for patients to integrate such information into their perioperative care pathway. From our contextual inquiry stage, we were able to get insightful input from anesthesiologists and nurses closely involved with pre-anesthesia consults. All the data gathered points towards common considerations about the supplementation of clinicians' job with an AI tool in future directions. This word cloud summarizes the common themes identified throughout the contextual inquiry process.
Let's delve into the current pre-anesthesia care standards. Hospitals offer early patient education resources like websites and guidebooks. Ottawa Hospital coordinates high-risk pregnancy PACs, while Sunnybrook uses digital assistants for complex cases. Despite these repetitive queries and persist in consultations, this reveals a gap in information delivery. France's proactive patient care with mandatory PACs since 1994 starkly contrasts Canada's more reactive approach, potentially missing broader consultation benefits and leaving expectant mothers with unanswered anesthesia questions. At Toulouse Hospital Center, MyAnest, a digital conversational agent, complements traditional PACs, enhancing patient knowledge. This significant care standard shift demonstrates digital tool benefits in patient experience. Our discoveries led to establishing our interventions design requirements. It is a digital innovation, addresses non-clinical questions, and improves understanding of anesthesia care. It is available 24/7, accessible, low maintenance, and adheres to privacy guidelines. Our project primarily benefits patients, enhancing satisfaction and reducing anesthesia-related anxiety. Other stakeholders like healthcare professionals and institutions also gain. Hence comes our research question. Can an AI-powered chatbot effectively disseminate obstetric anesthesia information in a pre-anesthesia setting to enhance patient satisfaction and preparedness? Our objective is twofold. Develop and validate an AI chatbot for non-clinical inquiries, measure its impact on patient satisfaction and preparedness. Our study explores AI chatbots' impact in pre-anesthesia consultations, filling a critical gap in Canada's PACs, reducing healthcare professionals' workload, and revolutionizing patient education and satisfaction. Methodology. Phase 1 focuses on building the chatbot's knowledge base and configuration, followed by preliminary evaluations by obstetric staff anesthesiologists and assessing 10 chatbot responses. Phase 2 involves meticulous data collection, analysis, and interpretation. 20 patients will interact with the chatbot. Their engagement and satisfaction levels will be measured, ensuring a thorough evaluation of the chatbot's performance and impact. Project timeline. We have completed a literature review and developed a chatbot training model, awaiting REB approval to finalize step 2. This step sets the stage for data collection and analysis. Post-tech support meeting, we identify key technical needs for our AI chatbot using ChatGPT 3.5 Plus Turbo and a text embedding model with secure data processes and optimizing token usage. Financially, initial tests with ChatGPT 3.5 Turbo were costly. Refining our training, we significantly reduced the token usage, maintaining the response quality. Annual chatbot implementation cost at Ottawa Hospital is around $668.56, about 850 Canadian dollars, translating to roughly 70 Canadian dollars a month. The budget adjustments may follow post-test patient interactions, yet we expect minimal changes. Post-initial goals, we plan to involve physicians and administrators, scaling our chatbot for broader healthcare impact. Finally, meet our supportive PAC team, essential to our project's progress and collaborative efforts continuing. Speaking about some of our key learnings so far, first, understand and identify the problem. Identifying the problem is crucial. The more you spend time here, the easier it will be to figure out and solve. Second, get the support you need. Most of the time, the right people can be found in your own network. So that means networking from earlier on stages is very helpful. Third, be open to receiving feedbacks. This can help a lot with choosing what and how to present your project. Thank you. We will be happy to address any questions you may have.
Questions? Lina?
Do I need a mic? Hi, great project. And my question might be dumb because I don't really know anything about AI, but I was just curious, like, how do you train a chatbot? Like, what does that mean exactly? I'm curious to know.
Elliot, do you want to take it?
I can take it, but I think you're pretty good. You're pretty ready to answer this question. But basically, Alina, you can upload some information into the chatbot, into the ChatGPT platform. We use another platform to do that. It's called Llama Index. So you can upload papers. So we will narrow down your question to the chatbot using all those kind of information to find the best answer within this realm. So what happens is that it doesn't bring all the information through all the data that is input there around the world. It's kind of narrowed down, and that's why Shalini was talking about tokens, because ChatGPT, when you input there, when you upload some papers there, it will kind of divide this information in tokens, and we will use this information to focus more the answer of your question on this specific realm, not with the worldwide data that is imputed there.
Specify your sources. Or one more question.
Planning on training the AI on clinical resources, how are you going to make sure that since
I'm
it's
the person is talking.
They can, well.
Hi, if you're training it on clinical resources, how are you going to, during like quality improvement testing, how are you going to ensure that it's using appropriate vocabulary for patients and people?
Exactly, that's a good question. Thanks for bringing up. That's why we have a step in the phase 1, which is validation with the expert review group. So we'll be recruiting experts before we test it on the patients, and that group will actually evaluate our chatbot responses. And moreover, the chatbot is trained with very highly validated and evidence-based resources that we have obtained, and we do not want to talk about the details right now. For this presentation, we will cover it up later, but that's what we're going to do. Yeah.
Thank you.
Thank you.
I have a shock to everybody and an important announcement for me that I noticed it's been a year of changes and unbelievable circumstances. The solar eclipse is not going to happen for another 100 years. But I just learned of some other news that I wanted to share with you that is equally as rare and unbelievable. I wanted to say congratulations to Jamie on his recent engagement. Someone said yes.
Okay, let's do. I thought we would announce that in a tab where we can actually post.
Oh, you toast after, I was just shocked.
Okay, let's take mine.
Much love.
It's roasting. What's happening?
She's finished.
Couple more, almost there.
Once you're good.
So I have to say that the dialogue in relation to us meeting Vegas last week, it's on you meeting.
So we're gonna do a casino.
It's a gamble.
Okay.
Yep, just drop the laptop on the other one.
Yeah.
Pop it up. It's good.
It's not procrastinating.
Awesome. There you go.
Good evening, everyone. I, Sarah Williams, presenting on behalf of my Capstone group, which also has fellows in my team. Welcome to our presentation, our Las Vegas themed presentation, revitalizing tenant health and wellness. We hope you experience some of the essence of Las Vegas that we experienced when we presented our poster recently, which we will discuss later. In this presentation, I will be introducing to everyone our project briefly, discuss our continuing research and collaboration, our finding from last week's Translational Science Conference, and our project next steps and some key takeaways. So who are we and what are we doing again? Let me walk you through our journey so far. In August of last year, we formed a partnership with West Toronto Ontario Health Team and Toronto Community Housing Corporation. They have come together to address the needs of residents in 2 affordable community housing buildings by developing a health and wellness hub to make relevant, diverse resources available to the vulnerable residents of these housing communities. We onboarded as student researchers with the goal of helping out in some way. Therefore, to help us determine our role, from September to February, we conducted contextual outreach. We attended multiple social events. We worked to build relationships and trust with tenants, as well as understand their problems and how we can best serve their needs. At previous points, our research goal was out of scope or didn't closely match our identified needs well enough. Very significantly, in March, we reanalyzed our problem statement, research question, and project scope with our TAC committee after their critical assessment. This shift in perspective and narrowing of our problem has allowed us to better identify what we are tackling and how we restructure our focus moving forward. So that brings us to our question. Well, we are excited to solidify this research focus with the help of our advisors. Our current problem statement is, at 100 High Park, there is a lack of an evidence-based strategy for TCHC to capture and incorporate the health and wellness needs of their senior tenants in the development of community programs. So how might we engage our senior community members at 100 High Park Avenue to identify and address their health and wellness needs? Importantly, we wanted to be able to marry existing contextual outreach with the work that is centered around implementation of a wellness hub with our new scope of determining how we can engage our population. Therefore, In order to do this, we will be developing our community engagement strategy while we engage with our population during the development and implementation of the Wellness Hub. We also find this beneficial as it gives us relevant topic already familiar to our residents and provides an environment where a community engagement strategy can be sustained after our project ends. So let's look a bit more at the research that we've done to identify these needs. Our in-person on-site contextual outreach has mainly spanned 3 events starting last summer, bringing us to over 100 responses. We got these primarily with talking with residents directly, one-on-one, or with interactive engagement such as figure boards. Across all events, we asked questions such as, what is it like living in this building? How would you describe your health? What are some of the potential needs of tenants? Furthermore, we've had comprehensive meetings with all the stakeholders involved in the creation of the community hub. This includes TCEH, Western Ontario Health Team, and select primary services that are currently provided in the Wellness Hub, such as Connect Care and Spectrum to name a few. We discussed the problems we gathered and brainstorm interventions to implement and evaluate over time. Now we're going to discuss what we gathered from the conference. The conference was a great opportunity to go through the various aspects of our project and practice getting our message across. But one of the most valuable aspects was our ability to network with other scholars who provide us with feedback and share some of their overlapping methods with our own project. To name a few, one poster in particular had a framework composed of 4 pillars for community health and engagement, which included education and resources, collaboration and partnership, outreach and service, priorities and perspectives through a health equity lens, and with the intention of building strong and trusting relationships with community members, which was very relevant. We also attended a keynote speaker presentations, which discussed biases, health equity, and research efficiency through real-world scenarios. So whether it is a research poster that has a title that is very similar to our own goal, or a speaker event that may not seem directly relevant at first, it was very helpful to connect with a diversity of scholars and projects. Moving on to our next steps. We plan on conducting focus groups to understand how student communities want to be engaged by TCH. We'd like to draw on themes and analyze data collected to inform our intervention pending our web approval. And we plan to provide a standardized recommendation on how TCH can best engage with their tenants to understand their health needs. Finally, for takeaways. Firstly, navigating web. If you haven't done so already, it can be very challenging. The interface isn't very user-friendly, so familiarize yourself where to submit and where you will receive your feedback, so that you can not prolong the process even further. Additionally, after attending the conference last week, as we discussed, we highly recommend you participate in closer presentations next year, being your first year. It's a great way to receive external feedback, connect with researchers, find employment opportunities, and gain confidence with your elevator pitches. We also wanted to stress that pivots or changes can be made in the game as well. Don't be attached to the vision or timeline you had anticipated, because things change. Pivoting does not mean starting from scratch. You can still leverage the work and research we've done, and you might just have to shift your perspective and your scope. Thank you very much, and now we'll go into questions and feedback.
Thank you. I vote for the scene.
So I think you mentioned about the conferences that it helped you convey or helped improve your messaging of your research to people. Something I struggle with conveying my research consistently across different groups. So wondering if you could elaborate a little bit more on what you learned from the conference with respect to that, and maybe what are the reasons for this. Maybe I could use to convey my research work.
That is a great question. I think it's very relevant to our project as well, because even before the conference, we found that at different CAC meetings, different meetings with stakeholders, different interviews, depending on who was there representing our group, people kind of just presenting different things. And it wasn't the most consistent, so it was very important for us to sit down and really get a great understanding of our project. And this is something that actually came up as a question. I believe it was in first year actually. A student from our program asked the question, how do I communicate what it is that we do at TRP? I kind of just say something different every time. And Joseph, I don't know if you remember, he said that's actually good. So you're tailoring your response to whoever's asking. As long as you had that session where you truly sat down and understand what you're doing, it's okay to change your response and tailor to who you're talking about. It's just about having that confidence at first and then describing it in the most appropriate way in that context, whether it's a 1 minute elevator pitch, a 3 minute thesis, or more like prolonged 10 minutes. And practice as well.
Okay, thank you, Christina.
Can everyone hear me? All right, so hi everyone, I'm Christina, and my Capstone project is aimed at developing an implementation model for a systematic hepatitis C screening program in hospital inpatient units. So I'm going to start by providing a little bit of background. Hepatitis C is a virus that can infect and attack the liver, and if the body is unable to clear the virus by itself, it can develop into a chronic infection that can eventually lead to liver failure, liver cirrhosis, or even liver cancer. Often, no symptoms appear until the liver is severely damaged, and so hepatitis C is considered to be a silent disease. Now, the good news is that hepatitis C can be cured. Currently, we have medications that are available that can cure over 95% of people with hepatitis C infection. The challenge, though, is that if people don't have symptoms until the liver is severely damaged, they won't know to seek treatment. And so testing for hepatitis C is the necessary first step towards linking those who have hepatitis C infection to the treatment that they need. Currently in Canada, there are significant gaps in testing and treatment for hepatitis C. 25% of people who have ever had hepatitis C are not aware that they had an infection, and only about a little bit less than a third of people who are living with chronic hepatitis C were actually treated for it. So currently, there's a group at UHN called ViroCan, and they're aiming to increase the diagnosis and linkage to treatment for hepatitis C by exploring systematic hep C screening in hospital inpatient units as a potential intervention. And currently, they are conducting a pilot study that's evaluating 2 models of hep C screening in participating inpatient units. And this is either a conventional serum test, which is just a simple blood draw, or a rapid finger stick test, which is a newer medical device that you can prick someone's finger with and just a little drop of blood to do a very fast test that's much quicker turnaround time. And they're basically aiming to evaluate and compare the ability of these 2 models to increase linkage in treatment. Now, of course, a successful hepatitis C program, screening program, is not only one that can effectively increase the amount of rate of linkage in treatment, but it's also one that is human-centered in that it is well tailored to the needs and realities of both the patients and the healthcare professionals and staff that are currently in the inpatient units, but it's also one that is feasible and sustainable to actually implement and integrate into the clinics. And this is where my project fits in. So the research question that my project needs to address is how can a point-of-care systematic screening test for hepatitis C be implemented in a way that is feasible and adopted by patients, healthcare professionals, and other key stakeholders. And the project objectives, essentially, the first 2 bullet points is to really assess the acceptability and feasibility of introducing an additional screening test onto the units from both patient and healthcare professional perspectives. And then the third point is to determine what optimal integration looks like in terms of being able to implement screening tests into current workflows and also the current patient journeys. And finally, I aim to develop a proposed implementation model for the screening tests. So the methodology centers around written surveys to both patients and healthcare professionals. So the patient group would be those who have participated in hepatitis C screening through the pilot study. And this is to understand their experiences with the testing and assess the level of acceptability from their perspective. And the healthcare professionals are going to be the ones who are currently working on the inpatient units, but they're actually not the ones delivering the tests in the pilot study right now. Eventually, we hope that we will take over. And so this survey is to assess the perceived feasibility of adding this additional testing step to their workload and workflow, and how we can do it in a way that's less disruptive to how they're working right now. Main deliverable is, as I mentioned before, a proposed Hep C screening program model, specifically how to integrate this testing optimally into current workflows and patient journeys, and some anticipated impacts with the findings of the study could inform the decision-making of the team when it comes to deciding is it worth implementing this program as a more permanent program. And then secondly, it will ensure that the program design is better tailored to patient and healthcare professional needs. And finally, by engaging with the staff on the units and the healthcare professionals through this survey process, this raises awareness of this project that we're hoping to do and opens lines of communication early on key stakeholders. So that when it comes time to actually going through with the implementation, everyone's already aware about what we're trying to do. So in terms of project progress so far, I put the project proposal up there as the first one because, as many of you might know, setting up the project itself has been quite a journey in terms of pivoting from different projects and different topics before landing on this one. Recently, I did get review approval and packet assembled, so we had the first meeting last week. And so currently, I'm in the data collection part of my project where I'm going into the hospitals every day now to do surveys. In terms of next steps, one of the most immediate ones is to continue to refine my strategy for approaching healthcare professionals for surveying, especially since they're incredibly busy while they're on the units. We're also continuing data collection, prepare for data analysis, and scheduling that. Just wanted to highlight 2 key lessons learned. I think the first one, a lot of previous presenters already touched upon this, but just to reemphasize that it's really important to be very clear in defining your project scope because it can get very broad very quickly. And secondly, I found that having an effective and concise project pitch was really helpful in getting support, especially once I got into the units itself and people are very, very busy and tight for time. So being able to convey what it is I'm trying to do in a very short amount of time is really helpful in gaining your support. So thanks very much for your attention, and I'd be happy to take your questions.
Nigel, I guess you'll repeat the question because you have the mic.
Oh, okay.
Okay, so my question is, you're going with an inpatient approach for testing. And what I want to understand is that because that's where the highest risk population is, or is it a matter of scale? Because future step in the brain is, pharmacies are looking to engage with simple tests. They do HbA1c tests for diabetics, and they know how to send results directly to your family doctor because if you already have prescriptions going. I don't know how easy your present test is, it's that easy. And the healthcare professionals resist, or like you just want to scale up options. Just like trying to understand like why you do that.
Yeah, so thanks very much for your question. And I believe that
So the question is,
oh, sorry, so for those online, the question was, why are we investigating inpatient units as the site for implementing hepatitis C screening program, as opposed to maybe pharmacies, for example, that might also have the capacity to do this type of task.
Or there could be two good things in step one, step two.
Yes, or it could be that's a similar process. So the answer to that question is the group that I'm working with right now, which is Biocamp, they have multiple ongoing projects, so they're kind of like doing these pilot projects in different settings simultaneously to see which ones are working, which ones are not. And one of them is focused on the pharmacy side, and they also do like community-based screening. So this project specifically is more hospital-based. Prior to this project, they had one that was based in the emergency department, and the reason is because a lot of people who go to the ER might be those who might higher risk of Hep C, especially those who might like drug users are typically higher rate of Hep C, so we tend to catch them more in the ER. And then I think the inpatient unit is that a lot of people who go to the ER might actually go to the inpatient unit as well. So this is kind of excellent to that previous.
Lena?
Yeah, so my question is kind of like three-part. So, but it's concise, so in its parts. So one is, and I'm sorry if I missed it, but how is it being decided who will get the screening? And then is the screening like optional or mandatory? And if it either or, how would you address whether if someone disagrees to having the screening? Because there is a lot, like in a lot of different cultures and groups and stuff, I guess like going for screening is something that they don't want to do because of their
Yeah, definitely. So for those online, this was a three-part question. The first part was how do we determine who you approach this screen? So I'll answer that one first. So we have a research nurse on our team who does the pre-screening every day. So every day they get the list of like who are the new patients that are new admissions to the unit, and then we screen through those patients. So for this particular study, we are only screening those who are adults, so 18 years or older. So that's kind of the first screening, and then they're also screening for like their kind of conditions. So we tend to like not approach patients who are like in the oncology unit, for example, or maybe those who are like not in great condition to be approached for screening. And I think there is also the consideration of whether they're like infectious disease, so it's like are they contact or droplet. Just keeping in mind that like our research staff, we want to like limit their potential exposure to like infectious disease. So that's like another consideration for this particular study specifically. But once we like actually implement this as like a permanent program, there would be much less restrictions on this. Like this would be eventually, hopefully, everyone who comes onto the unit would be offered the test. Second question was, is it
Is that optional or mandatory?
Okay, yes. So right now, as a study, it is optional, so you're forcing it once you get screened. And I believe, and this has not been decided, but I believe it will also still be optional once it's officially implemented. And then the third question is, what is someone?
Yeah, like how would you address screening hesitancy? Because if no one is choosing to do the screening, then how do you do it?
Yeah, so the question was, how do we address potential hesitancy to do screening? Right now, the main strategy is through like education and giving that like explanation at the beginning about what is Hep C, what are we doing, why is it important? And a lot of the surveys so far, people have been saying like, we want to know more about this, so this might be something to take back and consider moving forward to educate patients more so they can make that decision.
Okay, thank you. Next, your turn.
Okay, we're gonna get started. Whenever you hear me, and see, looks good. I'm Shayna, I'm joined by my team, Alma and Kelly, and we are prototyping after remotely monitor CAR T-cell therapy patients. During this presentation, you'll hear a background on our project, our plan, an update on our milestones and deliverables, what we've learned so far, and hopefully we'll have some time for discussion. So when we were deciding on our capstone, we first formed our team based on our interests and also working well together. Then we decided to focus in the cell and gene therapy area. We had to narrow our scope a lot. So through doing outreach and talking to different people, we did that and received feedback along the way. We eventually landed on CAR T-cell therapy, which is a third-line therapy used to treat refractory blood cancers like leukemia and lymphoma. Current monitoring involves general symptom monitoring, film checks, and diagnostic imaging. CAR T is a relatively new therapy, and there are quite severe side effects that might not effectively be monitored over a long period of time. Those potential side effects include infection and sepsis, CRS, and a type of neurotoxicity called ICANS. And these have to be monitored carefully because they're potentially life-threatening. The current state of the field is that patients require extensive hospitalization or travel back and forth to the hospital to be monitored. There's a lack of remote monitoring, as well as a lack of long-term data collection. And the protocols for monitoring are not currently standardized across different centers. The desired state is that patients would be discharged from the hospital in a timely manner using evidence-based practices. We would have remote monitoring that's effective, long-term data collection, and finally, we would standardize the protocols using evidence-based practices. I'll pass it over to Kelly to continue.
Okay, so looking at the big picture, in order to get from the current state to the desired state, there are a series of steps. Firstly, we have to develop the tools to remotely monitor the patients. Next, we have to do a large-scale feasibility study to validate the tool. Following this is the actual implementation of the tool, and then standardizing data collection, and then eventually using this long-term data to implement the best practices. So to try and address all of this, it's not going to be feasible within an 8-month capsule project. So instead, we're focusing on the first step, which is just creating the tool. So this brings us to our specific problem and need. The problem is currently there is no tool for remote monitoring of CAR T-cell therapy patients after they are discharged from the hospital, and there is a need for such a tool. Specifically, we want to know what elements and functionalities need to be included in this mobile phone application to provide reliable remote monitoring for CAR T-cell therapy patients.
So to accelerate the development of this app, we did find an industry partner. CareTrack Inc. is a company that has created an app to remotely monitor patients after they receive allogeneic stem cell transplants. They already have a functional app where the patients input self-reported data and vitals, and they also have the physician dashboard where there is real-time monitoring of the patients. So we will adopt the same fundamentals for the CareTrack's Allo app. We'll be using the Garmin smartwatch and other integrated devices to collect patient vitals. Symptoms will also be self-reported using the patient app, and physicians will be able to see this information on the physician interface. We have created a low-fidelity mock-up of how our version of the app will look in comparison to the current version of the app. This was put together using Visio and Figma and is subject to change based on the outcome of our study. These are more pictures of how the prototype looks. These are just Figma designs that we can change up based on the feedback we get. So our study specifically has three main phases. So first, the programmers are currently cloning the current app. After that, we will be recruiting participants with experiences and also healthcare providers. Then we will conduct semi-structured interviews and perform qualitative analysis of these interviews using in vivo. Finally, once we've analyzed the quantitative and qualitative data, we will further develop the app based on their recommendations. I'll pass it over to Anna.
So we recently received our RED approval, and so we are starting on a recruitment process for our interviews. We've been awarded our MindTax grant and have completed our preliminary framework for the app. In order to recruit people with lived experience, we are partnering with patient advocacy group LLC, so the Leukemia and Lymphoma Society of Canada, who will put our recruitment materials on their social medias. We have connections with CAR-T clinical coordinators at PMH and Jovinsky, who will present our study at their weekly meetings to recruit healthcare providers. Once our recruitment materials have been released, we will be booking our screening calls and then interviews, and we started the process of mapping the app using Figma shown before by Kelly, and created an Excel document with the static parameters of the app that will be implemented. And the Excel sheet right now has been sent to the programmers who we have met with to begin the process of creating the current app from the current app. And so this past week, we had the opportunity to present our poster at the Translational Conference, Science Conference in Vegas. We were part of the top 50 posters and got the chance to do an oral presentation, so that's good, Jane, hearing your presentation. And here are some key learnings. I know you probably heard this from everybody, but just quickly. So regarding the research ethics board application, it's very rigorous, but very informative, and it's extremely helpful to outline the details of the study before we started, especially our recruitment. Really important to define your capstone goals early and align as a group. So what would you guys want to get out of it? And make sure those align, and find your team member strengths and delegate tasks in so that everyone can do what they're really good at. And advice to the first years, networking is the best way to get your project started. Talk to as many people as you can and find people that align with your goals. Pick a topic you're excited or passionate about and choose a group that energizes you. There will be lots of setbacks, so find a group that's really good. And to narrow your scope as much as possible. You can always do more than you planned, but 8 months is really short and goes by really fast. And just a look at our project advisory committee. We've had a lot of help from our graduates, supervisors, classmates, and our project advisory committee. Dr. Ben Sankey, Aaron Hammond, Paul Eisen, and Keith Purdy. And acknowledging my times, care times, and TRP.
Thank you. Question? One question. Okay, so. Okay. Last but not least, Julia.
Okay. Well, thank you so much. I'm glad I'm last. I had a pretty colorful presentation, so I hope we could keep engaged until the end. And I really appreciate if all of you would stay probably until the end of the presentation. I'll try to keep it as concise as I can. I'm sure some of you have already heard that I'm working in the space of autism in children with Down syndrome. And before I move on, I want you, all of you actually, to think the very first thought that comes to your mind when you hear these two things together in one sentence, and hold on to that thought, and eventually, if any volunteers come up, please tell me if anything has changed after this presentation. So, what exactly is happening behind this project, and how exactly I came up working in this space? 2 years ago, I attended a conference about Down syndrome in 2022, and one of the workshops was actually discussing about this dual diagnosis. I signed up for this workshop for two things. One of them is at the end of the presentation, so you have to stay. And the first one was actually because I've been working in the healthcare space my entire life, I never heard about that. So I just really wanted to learn more about it. One of the presenters was actually a developmental pediatrician who was really well known in this space. And I was so excited about it. I started working and researching that I put up a proposal in year one as one of my courses, and I was so impressed when I presented to Joseph and Jenny. However, that meeting didn't really go quite well, Joseph. The expression was like, really? Eventually, it took me 6 months to gather evidence and quite a lot of work. I had to talk to people, and I gathered everything that I had to convince him that this is really a problem. It's not just worldwide, but it is existing even in the country, so we really need to work on this. I made the decision that this is going to be my capstone project, and I just moved on forward. So yes, moral of the story is that if Joseph says no, just go ahead with your instincts, work hard, and improve your project. Eventually, it's going to pay off. So, what is this project about? And let me just tell you what exactly is the challenge behind. Many of you probably never really associated autism with any other developmental disability. All they think about is neurotypical children, but never comes to our mind, well, what about the children who have different kinds of disabilities? How come they experience this kind of problem, and whether it is a problem even in the first place? Decades ago, a couple of researchers decided to publish a finding stating that these two have nothing in common, only because one is a neurodevelopmental disorder and the other one has something to do with genes. So how come they can be interacting? There is no way about it. And for some reason, that notion has been existing even today, even decades after publishing evidence that these two can coexist, and in fact, it was proven that actually children with Down syndrome are at much higher risk of developing autism. Right now, that stands something between 10 and 25, however, the numbers are probably even higher because of lack of research. On top of it, they are actually having around 40% of higher prevalence, which means that 4 in 4 children with Down syndrome potentially have a autism, and which is not being even recognized. And on top of it, there's an estimated 5 years gaps between when the onset of the symptoms started and when the diagnosis is being established. Let me just translate all those numbers and challenges. What exactly is happening in the real world, and why do we need this project? This one sentence that was published in one of the research papers in 2018 sums up absolutely everything. First of all, the diagnosis of autism is overlooked in children with Down syndrome. Clinicians are not aware about it, and the currently available screening tools are actually not considering children with neurodevelopmental conditions. And this is what is happening here in the Canadian healthcare context. In order for a child to get on board with the early interventions and funding which are being provided by the government, the diagnosis has to be provided before age of 5. And that happens when neurotypical children, they are going through a screening process when they're turning 18 and 24 months. By the time they're being treated, they're already being diagnosed, and they're just getting on board with absolutely everything they need for them to thrive in their life. However, talking about healthcare equity, that doesn't exist for children with Down syndrome. And for them, they have been deny, and I strongly say deny, screening for autism only because of that notion that autism does not exist in these children. They have exactly the same signs and symptoms which are occurring at around the same time, just like any other child. But only when things are not going quite well, this child was supposed to develop somehow despite having Down syndrome, then they're starting to think, oh, maybe this is somehow related to autism. By the time we actually figure out that this is something else, time has passed, and that 5-year mark is gone. So they have missed the boat for them to get on board for the early interventions. These children are usually being diagnosed with a dual diagnosis of having Down syndrome and autism by the time they're 7 and 10. And by the time they actually get those interventions, they're no longer early interventions, they're adolescents and unfortunately adults. So as you could have understood so far, the problem is that we really need to work on this because there is a significant gap in the timely recognition and diagnosis of autism. And for that need, we need to have proper screening practices, and along all of this, we need to have better awareness among the clinicians. I had 2 goals. One of them was really trying to understand and explore what exactly is happening in our Canadian context. Why do physicians really resist understanding that these two are actually coexisting? What is their awareness, and to what extent that awareness is actually impacting their clinical practices? And the second goal was I wanted to get in touch with the caregivers and trying to understand what exactly they need, what kind of challenges they have, and how we can support them in their journey. And this is what I did. I distributed posters among the Down syndrome associations across the country through emails, newsletters, and social media. The next step was I designed a pretty similar poster which was disseminated to the healthcare professionals through, again, emails, newsletters, and social media. And this has been the outcome so far. I'm so happy that I did get quite a lot of responses from the health professionals, although I was expecting these numbers to be quite opposite. But I did get a response from various health professionals from 4 different provinces: Ontario, the most, Quebec, Nova Scotia, and New Brunswick. And most of the caregivers were from Ontario and Alberta. By the way, this study is still going on, the research surveys are still being disseminated, and following these numbers and communication with so many associations and physicians, now the interest comes even more that I even started sending these posters to places that I never even thought that I would be posting. So this is what caregivers had to say in some of those interviews and some of the surveys. One of them said that they were naively believing that once they're going to get the diagnosis, they're going to get onto those early interventions, which I mentioned, but never really happened. And one of them mentioned that looking back and watching the videos, he could talk and point at things and then just stopped. He's 11 years old and we're still waiting for assessment. This is, by the way, an interview that happened just a few days back. And this is the moment of truth which I wanted to show to Joseph, that our problem in Canadian healthcare context do exist. Because these are some of the comments which were made by the healthcare professionals that doctors need to listen. Unfortunately, they don't. One of them mentioned, I would like to learn more about this combination because I have never thought of it. And another one that mentioned, I have never thought about this dual diagnosis for these two, and more research and information would be helpful. So I think that we really got it right. And again, you're still wondering, why do we need this research and this kind of project? One of the responses that I received from one of the clinicians had mentioned, I have had family doctors decline my recommendation to refer to multidisciplinary team or specialized services because they don't think the child could have autism. These are currently licensed practicing physicians in the country. And what do I need to achieve with this? Based on the responses that I received so far, they were demanding that I come up with an educational material which will be disseminated with the Down syndrome associations. They also want to see this analysis and being disseminated with the associations because obviously seeing is believing, and that's exactly what we're going to do. And the last thing is that I was surprised that quite a lot of them had mentioned that they never really had any kind of training on these two co-occurring conditions. So they're really hoping to see any kind of CNAs coming up in future. And my lessons learned out of this whole thing is that be patient. Sometimes things don't really happen. You may need to spend a couple of years until you're convinced. Next thing is that really network, and then do some network. It is going to make a huge difference. And the last point is that when you really truly believe in what you're doing, others will notice and eventually they'll get inspired and they're going to even advocate for you. I was surprised that I was forwarded emails which were forwarded by additional doctors and researchers without even me talking to them that they have been advocating for my study, and that was like really a good surprise. And what is the next step for me? I have been accepted to present this study at 2 different conferences. One of them it is coming up next month in May, and here in Toronto. That is the Pediatric Association, and that's my preferred target audience for this study. I will be flying to Italy in June to attend the Trisomy Research Society conference, and in July we have a conference on Down syndrome, which is going to be in the States. And I want you to present my team. I would have never been able to achieve any of these, and I really want to appreciate for all the questions, no matter how hard they were, but yes, eventually I did the right thing to actually try to push forward with this project. And I want you to go away today with one thought that Down syndrome is not a disease. Down syndrome doesn't require fixing. It is us who have to fix ourselves. We have to design a healthcare system to help them thrive instead of making them feel different. And the main reason why exactly I'm doing this, and when I told you to hold on to your last second on the last presentation on why did I sign up for that presentation of the workshop is, well, this is my daughter, she has Down syndrome. And me having a child with Down syndrome, being in a healthcare space, not knowing about these things, it just tells you how much this problem is really underexplored and really underrepresented when it comes to the healthcare community. So I really appreciate staying over time, and I'm welcoming questions.
I'm just curious about the response rate that you have and the ratio between physicians and other allied health and the other allied health professions where that actually responded.
Oh, yes, we do have quite a lot of physicians, most of them are. I don't have the numbers yet, only because we're still accepting the survey responses coming in. But I was surprised that I do have more responses from developmental pediatricians, general pediatricians, and early childhood specialists as well.
I'll say it's not a question, but I just want to thank you because I have my own lived experience like family members and stuff. But I just want to say like how meaningful it is that like you, especially in the beginning and closing the way that you did and saying this is not a medical condition, it's not something that needs to be fixed. It's just super important to get that message out.
Thank you.
Thank you, everyone. I think this is great. I always like those. One thing that, so before we go to the pub, I just wanted to say that on May 14th, we're gonna have one of those Get Talking events, and I would really encourage all of you to be here, first years and the second year, because it's going to be the Associate Minister of Mental Health and Addiction that is going to come together with his chief of staff and talk to us about the recent policies, but also what's coming down the pipeline of the issue.
So in case those that are online did not hear that, Tita has managed to cage or finally trap the person who keeps the deputy minister's schedule, and it is now written into his agenda that we will be here on May 14th, barring some act of God, I guess. So please do try and come when Advita and others make such an effort to make somebody who's a sitting deputy minister come to our class to talk to you. It's a pretty big deal.
But it's not even that. The most important is like every one of you was just saying, networking is the most important part, and you never know when you're gonna need one. You're probably always gonna need somebody close to, but you never know when you're gonna need somebody for a particular project, even though they might not be dealing with mental health right now. But at the end of the day, everything is good. Oh, it's 4 to 6, so it's in the 4 to 6, so it's the regular deadline. So we'll send out, and like I said, it's still kind of happen, so we'll send out.
And we'll try and include both cohorts.